welcome to our web conference today, Health Equity Approaches to Preventing Sexual and Intimate Partner Violence. And if this is an overview, a way to build a foundation. Prevent Connect is a national project of Valor US, sponsored by the US Centers for Disease Control and Prevention. The views and information provided in this web conference do not necessarily represent the official views of the US government, CDC, or Valor. Okay, so we've got a couple of objectives that we will be focused on today. So the first one is really just getting to a place where we are comfortable defining and explaining the concept of health equity. I don't know about you all, but I often understand things in my head, but I cannot say them to other people. And so sometimes when we're working with like complex issues and language that we might not be super familiar with, I find that happens. And so we really want to just kind of practice. How do we define health equity? How do we explain it as a concept? What are some of the factors that contribute to inequities in health and health disparities? And then why does health equity connect to sexual and domestic violence prevention, and what are some health equity approaches to prevent violence prevention? So those are all things that you can expect. And you will not have to hear from me for much longer because we have a really wonderful guest presenter today, someone that I have learned so much from and really look up to, Mighty Fine. Mighty is the director at the Center for Public Health Practice and Professional Development at the American Public Health Association, or APHA. And Mighty, I am going to share a little bit more about you in a few minutes when I hand it over to you, but I just wanted to give you an opportunity to say hello to our guests. So I'll let you do that.
Hello, good morning, good afternoon, everyone. Looking forward to spending some time with you all today, albeit virtually, but it's still time well spent nonetheless.
Thanks, Mighty. So I'll share a little bit more about Mighty in just a minute, but right now I wanted to turn to you all and hear from you and just kind of like, what does health mean to you? When you think about health, what are things that come up? And so if you want to share your thoughts around health in the chat, it'd be great to see how we're all kind of showing up today, thinking about health. Kirsten says balance. There's no right or wrong answer. It's just, what does health mean to you? I think it means a lot to all of us. So I'm seeing well-being and wholeness, holistic well-being, proper functioning. Health means security, happiness. Ryan says guilt and shame, to be honest. Thanks for sharing that, Ryan. Care, state of well-being, quality of life, safety, joy, autonomy, self-determination, more wellness. So I see certainly a theme coming up around it means wellness, well-being. Lots of you are delineating between, there's different types of wellness and health. So physical, mental, emotional, it's more than physical. Yes, Tammy. Access to meeting needs, no life limitations. Thank you for that, Tammy. Lots more wellness, quality of life, full potential. Thanks, Laura. There's some really great comments in here. Accessible health care. Privilege, confusion, more overall well-being, thriving, self-actualization. Yeah, thank you all so much for all of those comments. I think it really gets to the fact that health isn't just about being sick, let's say, or like the absence of an illness. Health incorporates so much more. It's physical, it's mental, it's our social well-being, and health is a basic need. It's a human right, and we all really deserve health and deserve access to what makes us healthy, because we don't just attain health, by waking up in the morning. And so, and there are many factors outside of our own personal control that affect our health and our ability to attain health, that Mighty will talk about more as we go through this. So thank you all so much. Appreciate you for engaging in that question. So there have been some resources in the last couple of years that have really looked at health equity and specifically sexual and domestic violence prevention. And so two of those resources are from some of our national technical assistance partners. And I'm going to put links in the chat if you haven't seen these. But the first one is a Back to Basics publication that was put out by the National Resource Center on Domestic Violence and the National Resource Center on Domestic Violence and the National Sexual Violence Resource Center. And so this document is really about partnering with survivors and communities to promote health equity and looking at the intersections of sexual and intimate partner violence prevention. And then a health equity approach to preventing sexual violence joint publication by Prevention Institute and the National Sexual Violence Resource Center. And I highly recommend both of these if you haven't had a chance to read them. I'll share a little bit about what you can expect to find in them, but this is really a good kind of starting place for connecting violence prevention work to health equity. And so just to kind of like start us off before we pass this over to Mighty, when we think about, what is health equity, there's lots of definitions of health equity in the world. But this definition from Prevention Institute, I think says that, it's about giving every person, no matter who they are, the chance to be as healthy as they want to be. And to do this, it requires that we remove some of the barriers and obstacles that keep people from being able to attain health. So things like poverty, discrimination, lack of access to good jobs or education, safe housing, and safe neighborhood environments. And so this is kind of the definition that we'll use to frame our conversation today. And again, you can find it in the Health Equity Approach publication. We move on and think about, why are these issues of violence related to health equity? Why are they health equity issues? And one thing that this publication points out is that systemic issues have really created a disproportionate level and burden of violence on some communities. And so, we think about the long history of systemic racism and oppression, what it's done to communities to put a disproportionate burden of violence. There's policies and practices that have created really concentrated areas of social and economic disadvantages. And then also experiencing violence or the fear of violence really kind of undermines health equity. Nobody can achieve optimal health when violence or the threat of violence is present. So sexual and intimate partner violence is a health equity issue, and preventing it is really health equity in action. The Back to Basics document, I think, emphasizes that it kind of sums all this up, right? If we think about what a world without violence would look like, it's a world where people and their families and their whole communities are healthy. And I saw this a lot in the chat. They're healthy, they're thriving. And we see that to get there, we need environments where people can really bloom and be healthy overall, which is exactly what advancing health equity would provide. So I love that the Back to Basics publication really lays out that health equity is our work. Preventing violence depends on health equity. We can't prevent violence if there are inequities in health. So moving on, that is all good and great, but what is a health equity approach to preventing violence? Like, what does that look like? And so I think there's a couple different ways that we can look at this. And so one way is that a health equity approach to preventing violence recognizes that prevention efforts historically and currently are not distributed equally. And some communities may need more prevention strategies or different strategies than others in order to prevent SB and IPV. And so if we take a health equity approach, we acknowledge that, and we are not just kind of focusing in areas where there isn't the highest need. A health equity approach also really acknowledges race and class and sexual orientation and ability into the whole range of prevention work. So developing it, implementing it, and evaluating it. It's also really important for prevention efforts to consider some of these societal conditions that have disproportionately placed a burden on communities. And so thinking about how our prevention work includes conditions like poverty or racism, or anything really that's limiting opportunities for people to grow up in healthy and violence-free environments. And so we see that through a health equity approach, addressing the root causes of violence, having an anti-oppression lens is really critical to being able to prevent violence. And so there are some examples of ways that this is happening, and people have been advancing health equity and sexual violence. And so some of this looks like elevating community leadership, really, letting the community lead prevention efforts, letting the community tell prevention practitioners what is actually needed, and lifting up that leadership and resilience to create space for healing and prevention efforts. There really isn't a space where there aren't survivors of violence and people who have experienced trauma. And so are we really holding space for communities to heal through our prevention? Looking at our own organizations and thinking about how do our own organizations either advance or hinder health equity, and kind of assessing that and making those changes. Lots of prevention practitioners that are addressing the underlying factors that really contribute to whether violence exists or safety exists. And none of this can happen without partnering across fields and movements. So taking a multi-sector approach is absolutely essential, I think, in prevention, but absolutely in advancing health equity. So those are just some examples of kind of what is happening out there. And the resource document, I'll put a link again in the chat, will connect you to some of those actual examples. The Back to Basics guide, just real quick, and then I'm going to pass it over to Mighty, does have some suggestions for how we can build capacity to advance health equity. And so you can read all about these in more depth in the Back to Basics guide. But again, there are ways for us to build capacity within our own organizations to advance health equity before we can then, incorporate health equity approaches into our prevention work. So I think that's a great place to start. So let's see, I'm going to bring up Mighty's photo again, even though Mighty's on camera, and let you all know, I introduced Mighty as being from the American Public Health Association. Mighty's portfolio focuses on enhancing health science, policy, public health practice, and public health leadership. And Mighty's efforts are not only to prevent disease and infirmity, but also to bolster opportunities for growth. for development and for self-actualization for individuals and communities. And in Mighty's free time, Mighty enjoys both domestic and international travel, reading science fiction, and spending time with family and friends, which sounds like just, I don't know, Mighty, I just love you so much, and I'm so happy that you're here to present. So I'm going to pass it over to you.
Thank you so much. Yes. And Dr. Triplet, I see you said free time in there. What I should also say is that this new sort of phase in my life, I've refocused to this life-work balance where I love the type of work that I do and I appreciate it and so tapped into it. But I also had to reframe it and recognize that my life and all of that comes with that has to take precedence over work. So from my free time, that's when I do my life stuff. Thanks for the intro, Ashley. I appreciate it, and great to be here with you and everyone else today as well. So just picking up where Ashley left off, sort of my agenda for today is really to go over some definitions of health equity, to examine the determinants of health inequity, define racism and racial equity, because that is a focus of APHA, and describe a health equity approach that we've used in one of the programs that I oversee here in the Washington, D.C. area. And again, just as a caveat, it's not specifically related to my work at APHA, but more so in line with my work as a practitioner who engages in community health work. I usually like to start my talks off by saying I'm proudly hail from Brooklyn, New York, and I credit living in Brooklyn and also moving from there to more rural parts of this country with really cementing my understanding of how resources are distributed and to understanding the structures that we're still contending with to this day. And honestly, they really shaped my views on violence and violence prevention before I even knew that I would be working in this space. But again, I think it's just a testament to our exposures, and what we've experienced in childhood certainly play out in a multitude of ways in adulthood. Sort of picking up on that work as a child, moving into my teenage years, I was working as what we call High Tops, and it was a health interested teens own program on sexuality. And the reason why I find myself bringing that up all the time is because we focused on sexual violence, we focused on harassment, sexual assault, sexually transmitted diseases, and as teens, the work empowered us to be in touch with our own health needs, but also to promote public health principles and approaches to other peers, teens, and to folks throughout the state of New Jersey. So again, I like to lift up those two experiences because I really feel like that they have contributed to the public health practitioner that I am today. Again, just for the purposes of grounding some of this, I'm sure most of you are familiar with, but I think it's important for us to elevate these definitions when we're talking about health equity. So oftentimes folks will conflate equity and equality. So I found these graphics on a blog that I was perusing, and when you get the slides, you can check it out in further detail. But I thought it did a great job of sort of defining the different pieces of equity, equality, and justice, and some of the other things we'll talk about. So as you can see here, easily depicted, inequity, we're saying that there's unequal access to opportunity. So I think that's pretty straightforward. We get that. And then moving on to equality, we realize that we want to evenly distribute tools and assistance to folks, right? So it's making the playing field equal. So you can see as depicted in this photo here, we've made the playing field equal by providing the same size ladders for both persons. But we know that's not an equity-based approach, right? Because in equity, we're seeing where the need is greatest and we're prioritizing that need. So which brings me to the next slide. You can see here that in the equity-based approach, the tools, resources, and supports for the folks that need it a little bit more are created in a way to meet those needs. So they're custom tools that identify and address inequity and inequality. And but you'll notice here again, they did a great job at depicting that the resources and tools are not evenly distributed, because so even with an equity approach, sort of making things equal and equitable, we see that the opportunities are still not equitably distributed. And so that's why in public health, in addition to a health equity approach, we need to really focus on this social justice perspective. Because why is social justice the goal? Because we know social justice and a justice-based perspective is fixing the systems to ensure that we have equal access to both tools and opportunities. So you can see here, there's sort of ropes placed in between the trees to straighten out, correct the systems of oppression for intentions of this conversation. And then you can also see that once the system is fixed, then we're ensuring that opportunities are bountiful for all persons, irrespective of how we identify. So it's an equitable based approach, but it's framed in justice. And I feel like it's always important for us to elevate that justice perspective, because that's where we should be working towards. So again, just sort of picking up on what Ashley mentioned, when we think about equity, we're thinking everyone has the opportunity to be on this level playing field with their peers, right? But it also means that we recognize that there's this unusual level of fairness to compete. So we have to incorporate an equity-based approach to ensure that that level playing field is fair for us all. I also like to point out that advancing equity is both a process and an outcome, right? So the process, we apply an equity lens with those who are most impacted, as already mentioned, by structural inequities and are meaningfully involved in the creation and the implementation of institutional policies and practices that impact their lives. So again, it's meaningful engagement, looking at those most impacted and thinking to yourselves, how are they involved in the decision-making to remedy some of those shortcomings? And also as an outcome, we achieve health equity when our identity, however we identify, will no longer predict opportunities, outcomes, or how resources are distributed to us. So again, we have to think about this work as a process and an outcome, with social justice being the ultimate goal. So what are some of the determinants of health? Folks, Ashley, you want to get our poll up for us? So what community level factor, sorry, go ahead.
Oh, no, Mighty. Yeah, so I think we're gonna ask folks to answer this in the chat.
Okay.
And so just thinking about, you all started off by sharing what health means to you, what you think about when you think of health. So what are some of the factors in communities or in society that you feel influence health? I think that's where we want to go next, and they're coming in.
Yes, they are. Poverty, yes, stress, yes, the poverty, health insurance, the language, motor vehicle safety, yes. Fast and furious.
Yes, yep. Clean water access, safe parks, food deserts, homelessness, language justice, transportation, healthy groceries. So lots about food I'm seeing, things about kind of like the physical environment, so parks and housing and transportation, environmental and climate, social supports. Yeah, there's some really great stuff coming up in here.
Absolutely. You all hit you hit the nail on the head for sure. And I think very indicative of what we're seeing in the chat. Some of this may be review to you, but we know that social economic factors, the physical environment, and healthcare, also known as the social determinants of health, account for more than 70% of our health. That's pretty big. And we also know that health status varies widely by the zip codes in which we're born and raised. And we also know that, unfortunately, the way our communities are set up, it's not by happenstance. We know that policies and other practices have situated certain communities to contend with these social determinants. So when we say social determinants of health, we're talking about the conditions in which people are born, grow, live, work, and age, and the socio and economic status, education, neighborhood and physical environment, employment, healthcare, and all of the other things that you all elevated in the chat. And so we know that the social determinants of health require cross-sector collaboration, and the primary goal certainly is to improve health outcomes. I think the other important part of this conversation is to talk about sort of concentrated disadvantage. So we know individually, these social determinants of health play a major role on our health. But when we think about them being concentrated in select neighborhoods, we know that that certainly exacerbates a myriad of poor health outcomes, including violence, both perpetration and victimization. So again, this idea that this is by happenstance, we know is not the truth. And so we recognize that our practices, our policies, and our approaches have to be systemic in nature if we want to address the social determinants of health, certainly individually, but also collectively when we see them operating within our neighborhoods. So how do the social determinants of health interact with violence? So cure violence, as I'm sure most of you are very familiar with, or ceasefire as it once was called, focuses on sort of violence interruption, and they look at violence as a disease and use an epi-based approach to deter and prevent violence. So this graphic really is a great indication of how the social determinants of health and violence interact with one another, and it uplifts violence in itself as a social determinant of health as well. So we look at the negative effects of violence on social determinants of health, including violence itself. So let's just take a few examples here. Education, we know, is a social determinant of health. And how is that impacted by violence? We know that it's diminished performance, lower attendance, decreased graduation rates. And we know that graduating from high school is such a great predictor for other aspects of our health. So we clearly want to keep kids in school and interrupt those patterns of violence to ensure that they can attend school in a safe and well manner. Economic conditions. We know that when communities are disinvested in and there are more derelict houses, there's abandoned lots, we know that drug use increases, crime increases. And again, we know that these all are things that are just not happening but we know that there are systems in place that exacerbate or create the likelihood for those things to happen. So with economic conditions and violence, we know that there's reduced business investment, reduced commercial activity, and then there's just despondence in those communities. Healthcare system as well, higher costs for violent injuries and increased chronic conditions because of that. The built environment, unsafe public places, leading to reduced usage. And we know that when you have green spaces and you have trees and you have parks and you have benches, we know that those are all protective factors. We know that that increases community connection. We know that that increases community cohesion. And we know those are all deterrents of violence. Community resources, more resources to public safety, high demand due to trauma. That can be a webinar within itself, so I won't go into it in too much detail, but we know that there are debates around how money is spent, particularly on a local level, and rethinking or retooling how those funds are distributed to ensure that they're meeting the needs of the community. And as I already mentioned, community cohesion, social capital, and those connections, we know that reduced cohesion and a sense of collective efficacy is impacted by violence happening in communities. And just by a show of folks in the chat, did you already sort of think of violence as a social determinant of health? Are you currently using this theory or this philosophy in your work? Be curious to see folks populate that in the chat as I move forward. Awesome, glad to see it. Somewhat. Okay, a lot of yeses, some somewhats. That's good. So we're all in the right place. And this is just something, when it was the Institute of Medicine, that I think is critically important it was then, and certainly it's important now when we're talking about violence and we're talking about social determinant of health. And sometimes communities are blamed for their conditions, which we know that it's the environment that dictates what's possible. And so what was stated in the report is that it's unreasonable to expect that people will change their behavior easily when so many forces in the social, cultural, and physical environment conspire against such change. So obviously we know about autonomy, we know about all of those pieces, but I think what's also critically important for us to do, and I'm sure most of you are doing this already, is to really think about how the environment can conspire against change that we know is healthy. I often elevate an example when I was doing chronic disease prevention for type 2 diabetes, and the physicians that we were working with all the time felt as if in some instances they were doing their patients a disservice, because we know type 2 diabetes is preventable, reversible in some instances by changing what you eat and being more physically active. And the physicians we were working with at the time knew that their patients were living in communities that had limited or no sidewalks, no green spaces. Folks didn't have gym memberships. There was a food desert. So even though they knew sort of the anecdote and promoted it, they knew that their environment did not support the change that needed to happen. So again, we have to think about the environment in the context of what we're promoting in public health. So we at APHA, thinking about with the IOM elevated, we optimize in our work the conditions in which people are born, grow, live, work, learn, and age, and work with other sectors and that influence health, including employment, housing, education, healthcare, public safety, and food access. And unique to APHA is that we name racism as a force in determining how these social determinants are distributed. And again, that's at the cornerstone of a lot of our work. We take it a step further and think about the determinants of equity. So monitoring inequities and exposures, opportunities, and disparity outcome, examining the structures, policies, norms, and values, again, seeing how these all interact with our health, rectifying historical injustices, thinking about how resources need to be distributed according to need, as I mentioned earlier, and transforming structures and systems of power, again, thinking about racism, thinking about white supremacy, ideology, and really thinking about how do we change that in our work. I think when we start thinking about concepts of equity and racism, those are pretty sort of broad concepts. And we know that one sector, one person is not going to change that. But the more and more we tick away at it as a collective, the more we can think about how do we really institute the change that we need to see, particularly when these things are so embedded in our culture. And then we look at the determinants of health equity to eliminate inequities and disparities, again, as I mentioned, to achieve social justice. And I often bring this to the forefront and let folks know that if you're in public health and the work that we're doing, it's really in alignment with social justice. So we have to be really intentional about addressing those things such as health inequities, racism, and alike, and be really comfortable talking about these things in a meaningful way and being able to showcase how the change really can happen, starting within our own organizations, which I'll talk about in a minute. So at APHA, again, we think about racial equity as health equity, right? And so when we think about racial equity, we think about the condition where one's race identity has no influence on how they fare in society. And I think this framework and this approach that we use can be adopted by any other identity when we talk about health equity broadly, when we're talking about orientation or ability. A lot of this is applicable across those different nuances of health equity as well. And it must be addressed at the root cause, not just at the manifestations of it. Again, so looking at what's undergirding it, looking at how when cities are districted, excuse me, and the tax base sort of like flows differently. So then we know who has access, what schools have access to what. So it's all of those things that we need to really think about in public health and broaden our perspective on racial equity and how that plays out in areas such as violence. And it also importantly requires the elimination of policies, practices, attitudes, and cultural messages that reinforce differential outcomes by race. So again, it's how we look at data, how data are aggregated or not or disaggregate it, and really even thinking about the experience of communities of color as a collective in America, particularly, but also taking time to think about those nuances and the differences among communities of color, and not always collapsing them as one shared identity, and having an appreciation of the unique challenges for the different racial groups within this country as it relates to racial equity. So again, looking at the racial equity lens, it's the process of paying disciplined attention to race and ethnicity while analyzing problems, looking for solutions, and defining success. Again, who's involved in the planning, the approach, the implementation, and it rejects a colorblind approach, right? Because we often hear, oh, I don't see color, and I want to believe, sort of the optimist in me wants to believe that that's coming from a good place, right? People are trying to convey that they are intending to be inclusive. But if you are intending to be inclusive, we know that a colorblind approach just does not work, because as well-intended as that may be, sometimes someone's skin is weaponized and they're seen armed, they're looked at being armed at all times, because there's just phenotypically, there's just no way for us to be colorblind in theory or in actuality. So again, that's something that we are very adamant about APHA. At APHA is really rejecting this ideology of a colorblind approach, appreciating potentially the sentiment behind it, but rejecting it as an approach altogether. And again, using a racial equity lens, it really helps to illuminate the disparate outcomes, patterns of disadvantage, and again, the root causes. So when we are thinking about the systems or structures that are at play, using a racial equity lens, or broadly an equity lens, really provides the space to uproot the things that are ongoing and cyclical in nature because of policies or practices that were flawed to begin with.
Okay, here's one of the polls, Mighty. So let me launch this. All right, let's see. All right, so the question that you're seeing is asking about what are the challenges that you encounter doing racial equity work? And so there are, I think you can choose multiple answers, because Mighty's asking for the top two. So hopefully I set that up correctly. So Mighty, can you see the results coming in?
Yes, I can see them coming in, so I'll be tracking them.
Great. Okay, excellent. So we'll give a minute or so for the most people to participate. Be great to get at least up to 50%. Oh, Delonda says, I don't see the poll. It should have popped up on your screen. You don't see it. I see a couple of you are, oh, a lot of you. Okay, that's very strange. I am not sure why some of you are not seeing it. There are a lot of people who are, so that is odd. I will have to look into that with Zoom. Okay, B says there's a poll tab down below. So if you try clicking on the poll tab at the bottom and see if it pops up for y'all, that might work. It could also be if you're using another device that doesn't support that, or if you have multiple monitors going. But I will do more research for next time so I can help folks better access that. Oh, thanks, Joelle. So yeah, sometimes a Zoom update doesn't happen. Okay. All right. So it does look like we have about 70% participation at this point, Mighty.
Yeah.
Kind of see how.
Yeah, so thanks for those, and sorry for those who were unable to participate, but it looks like it's hovering between a lack of understanding of the impacts of racism in health is sort of leading the pack there. And a close second is resistance to racism as a public health issue.
Mm.
And that certainly sort of bodes with what we've been seeing across the communities that we've been working with, and really getting folks to understand why racism is a public health issue and unpacking it. And I find it useful for us to talk about racism and health equity in the same conversations, because you can address some of the sort of anti-Blackness that we're seeing and the other challenges, particularly when it comes to concentrated disadvantage in communities of color that we know impact Black communities, but also Latinx communities at a different rate than some of our other communities when we think about inner city. And then it also allows us to talk about challenges to Native communities as well when it comes to resources. So we find that having that equity approach sort of opens the door, and then we can sort of tease it out and talk about some of the other challenges, and racism is certainly a piece of that puzzle. The one thing that, depending on time, we may talk about, you may remember around the time there were a lot of folks declaring racism as a public health issue. And again, APHA has been tracking which jurisdictions have been doing that, but also pushing folks to move beyond that and to declaring it clearly important, but really thinking about how is that impacting, and how do you unpack that, and how do you operationalize declaring racism as a public health issue? Are you shifting how resources are distributed? Are you looking internally at your organization? Are you moving forward a diversity, equity, and inclusion initiative? What does that mean to you by declaring it as an issue beyond the declaration? We're really pushing folks to do the work. I would be remiss in not talking with you all about the barriers to achieving health equity if we're really sort of ushering home the point that we support a health equity approach to sexual violence. Kamar Jones has come up with some barriers to achieving health equity, and I think these are the things that we have to keep in mind as we're creating policies, programs, and initiatives to address health equity. We have to consider these barriers. So this has come up in the chat, and I mentioned this already. There's a narrow focus on the individual, right? So when we think about violence as, why did you do that? Or I think the exhibit that we've had the privilege of showcasing at our annual meeting, what you were wearing. And I think this speaks solely to that, where folks are really thinking about what the individual did to put themselves in that situation. So again, it's a limited sense of collective efficacy. And then the systems and structures are invisible and irrelevant and are not at play when you have a narrow focus on the individual. So again, I think this goes without saying. I'm talking to a lot of folks who are doing public health work, but while we have an appreciation of individual, and there's sort of like individual protective and risk factors, certainly appropriate for the work that we do, but a threat to achieving health equity is a narrow focus on the individual without having an appreciation for the environment in which this individual operates. The other is this ahistorical stance, right? So the present is disconnected from the past, and the current distribution of advantage and disadvantages is just by happenstance. So when we don't have that appreciation for the past, there's the proverb, Sankofa, I know where I'm going because I know where I've been. And this is what that speaks to, right? So we cannot ignore the role that racism and all of the isms have played in society and have gotten us to where we are today. And how do we remedy that? How do we learn from those happenings and shift it from moving forward? How do we promote paradigm shifts? And how do we ensure that that's not continued? And by addressing, calling it out, and facing the history and the perils of the history in the country and in this work, that will help us to move the work forward. Again, back to what some of you illuminated in the poll, it allows us to see racism as a public health issue. It allows us to understand why a health equity approach is even necessary and needed, because we know that the playing field is currently inequitable and unequal. Again, just pop in the chat. Are you all familiar with these pillars? Have you seen them before? Is it something new? I'm curious to hear that as I work through them. The other is the myth of meritocracy, right? So if you work hard, you will make it, right? There was a video that goes around the time of Dr. Martin Luther King's birthday, when he talks about, you want me to pull myself up by my bootstraps, but some of our communities don't even have bootstraps, right? So it's this again, this myth of meritocracy. If you work hard, you'll make it because I did it. Recognizing that resources are not distributed the same. So again, it's very much that a myth. It also allows us to deny these inequities. It allows us to deny racism because it's creating the narrative that everybody in America has the same ability to make it, which we know is not the truth. And then an example that Dr. Jones always lifts up is 2 babies, equal potential, but is the opportunity equal for both of them? We know that that's certainly not true. So again, in your work, you have to really think about debunking the myth of meritocracy and how that shows up in your work. Again, the myth of the zero-sum game. If you lose, if I give, again, back to thinking about health equity and prioritizing, or thinking about social epidemiology and seeing where the burden is and how do we address those? Why are these folks more prone to disease, or why is this community more prone to disease? And when you start to look at the contextual, the social, the political factors, it helps us to answer those questions, right? But if we have this, the zero-sum game, folks think, hey, if they get more resources, that you're taking away from me, when you don't even need the resources in the first place, right? So it's debunking that myth, and it fosters competition over cooperation. An example that, again, I like to draw from history is sort of like Jim Crow. If you all recall, around that time is when Dr. King was working with poor whites and Blacks because he saw some of the similar civil challenges that they were contending with, and really recognizing that if you foster that cooperation, more can be done to support the needs of those communities. But as you all know, once Jim Crow was instituted, it was to showcase that even if you were poor and white, you were still better than Black, right? So it fosters that competition or that social comparison as opposed to the cooperation, and it masks the cost of inequity. The next one I think is sort of more idyllic and theoretical, and it's a limited future orientation. So if it, yes, it drives me bonkers as well, Gwen. When you borrowing from a lot of Native communities and East African communities, there's a huge emphasis on children and future orientation of our communities. So there's this limited focus on how are the children, particularly when you think about violence, certainly when you think about climate change and you think about these other challenges to our environment, we're so focused on the here and now that it doesn't create the space for us to think about the more equitable future for our children, because we're thinking and focused on the here and now. And again, if we're looking at how resources are distributed, you can make the argument that children are fine, but we clearly know that that's not the case. But when you have a limited future orientation, it allows you to focus there, and we know that that's to our detriment. The other is that there's this myth of American exceptionalism, right? So there's a disinterest in learning from others, and there's a sense of US entitlement. And again, I'm not saying that folks should not be proud to be American. Please don't confuse that. And I don't believe this was a sentiment of that either. But the idea is that there's so much that we can learn as a developed country. There's stuff that we can still learn from developing countries. When we look at disease rates in some of countries that would not be seen comparable to America, there's a lot that can be learned around, certainly in violence for sure, particularly when we think about gun violence. Most certainly we can learn from countries abroad, both developed and developing nations, and just opening up the idea that we don't have all of the answers, and by posing the questions, it sort of generates our collective minds to think about potential solutions to some of the ongoing challenges that we're faced with. So again, sort of ran through that quickly, but I in the resources thank you for putting that in there. It really helps us to understand how we in public health, if we truly want to advance racial equity, these are some of the pillars that we'll have to contend with and think intentionally about how to address. So as I mentioned before, some of the core work of APHA is declaring racism as a public health crisis. And I just want to give you sort of a snapshot of some of the work that we're doing there. Again, we know racism, and the definition is defined as a system of structuring opportunity and assigning value based on the social interpretation of how a person looks. The result of a system that it unfairly disadvantages some while unfairly advantages others, and it saps the strength of the whole society through waste of human resources. So Kamar Jones, this is her definition of racism, and this is the definition that APHA uses for our work. We look at the different levels of racism too. So the institutional, so differential across access to opportunities, goods, and services by race. We look at personal mediated, so bias, prejudice, and discrimination. And then we also look at racism as internalized by communities of color. So there's an acceptance of negative messages about abilities and your intrinsic worth. So our work tackles it at the different levels, and depending on the type of work you're doing, it's best to keep them all in mind, I believe, but there's some folks who just want to focus at the institutional level, but then we find others who are arguing that there are people who are responsible for policy decisions and things like that. So there's important to also address personally mediated racism, because we know there are people who are making these decisions. So again, I think there's synergy among them, but I've seen groups who have focused on one more than others, depending on the type of work that they're doing. So again, when we look at racism as a public health crisis, and we think about this certainly in the context of violence, we know that it's affecting a large number of people, and there's a growing demographic of communities of color that are living in concentrated poverty with limited opportunity, and there's an income and wealth gap. And again, as I mentioned before, we know that this is all not by happenstance, but using this health equity approach, we're able to critically appraise, evaluate, and deconstruct these structures that are exacerbating the likelihood of racism operating in the way that it does currently. It threatens health over the long haul. I'm sure most of you have heard about the weathering hypothesis, and really just thinking about the physical and mental toll that racism plays, how it plays out in disparities in life expectancy, rates of chronic disease, and maternal and infant mortality. Certainly violence is a part of that puzzle as well. And this is where I think it gets difficult for us, right? But just because it's a challenge doesn't mean that it's insurmountable. It requires the adoption of large-scale solutions. So policy and system changes versus individual intervention. I like to see before, or I like to always say how you think about like cancel culture, right? So someone makes a racially inappropriate remark online, or you see them in a video and they're fired or they're canceled. And it's easier to call out the racist action. And yet we know that the systems that support that behavior are harder to change, but it doesn't mean that we cannot change them, because there's certainly a need to change it. So again, that was just sort of like a high level, quick and dirty approach to our racial equity work. I just wanted to give a quick example of our health equity approach to some of the violence work that we're doing in the DC community. And then I think we'll have some time for questions, or if you need me to unpack some of the things that I went over rather quickly. So implementing a health equity approach, it's critical to our work, and I would imagine to a lot of the work that you all are doing, is community engagement and leadership. And by community engagement, I mean that in the most sense of the terminology, where we are going into the community and taking a back seat and creating the space for them to guide us. And they are occupying leadership roles within the space. We also address the underlying factors for violence. So in a lot of the work, we talk about education, we talk about economics, we also talk about sort of cultural nuances that when it relates to violence as well. And we also support social cohesion and healing. One of the projects that I think I'm most proud of is that a health equity approach that we use, and Ashley elevated this earlier in her remarks, is that we did healing circles. And I find that sometimes, depending on the spaces that I'm in, people sort of scoff at them and they don't have a broad appreciation of what the benefit and the utility that they bring to communities, particularly the communities that I've been working with and communities that have experienced some form of trauma, disinvestment, etc. So what we did was, so just backing up a little bit, it's a community coalition here in the DC area that was started around, there was an insurgence of violence within a particular neighborhood. So not even thinking, so those of you who are familiar with DC, you know that we're broken up into quadrants. We have Northwest, Southwest, Southeast, and Northeast. And there's tons of development and gentrification happening. So I won't go into the whole diatribe of what we're contending with that, but I'm sure you are all aware of what happens when neighborhoods start to develop and folks are displaced and the like. Anyway, we were working with community partners because we recognized that there was an insurgence of violence in a particular neighborhood, and it was gun violence, but there was also sexual violence and just like fighting happening. So some community members wanted to step in and see what they could do, and the city had some funding available for some intervention and some other programs that we applied for, but we had to amass a coalition before we did that. So we had a wide range of community members. Some were family members. We had law enforcement engaged. We had local clergy engaged, researchers from a neighboring academic institution, and then just community members. So it was sort of an open call, and we turned to them to find out what was happening, what was changing in the neighborhood. And we have found that because of some of the violence that was occurring in the neighborhood, there was a sort of secondary trauma that folks were experiencing, and not just violence, there was a lot of death happening in the community. So they were dealing with a lot of trauma. So what I also didn't mention is that we had mental health therapists involved in this work as well. And so we did two healing circles. The one healing circle we did, we call it the father and son healing circle, which I thought was fantastic. And it was focused on men, and it didn't have to be fathers and sons, but it was just men of all representations. And we talked about femininity, we talked about masculinity, and we talked about what it meant to show up in a relationship, and really created the space, a very open space for open dialogue around what people were taught and how they were taught to show up in the different relationships that they had. And we found that this healing circle was very cathartic, and it allowed folks to sort of peel back the layers of feelings that they had about being a man and what it meant to them to show up in a way that they were taught to show up, like what it meant to be masculine. We also found in this space that they didn't like the terminology hypermasculinity, so we didn't use that. And I also learned that the term femphobic, which I just had never heard of before. But anyway, in these spaces, you learn a lot, right? And so I leaned on the community to learn from them. And the reason why I wanted to elevate this is because from having these healing circles, in addition to some other program manifestations such as violence interruption, some mentoring, some recreational activities, and job coaching and job readiness, we found that within this neighborhood, the rate of violence had decreased over a year about 70%, which I found to be pretty astounding. And I would like to attribute a lot of that work to these healing circles, because it created a connection for folks. It rebuilt the community cohesion. And what we also found, as neighborhoods were shifting and changing in DC because of the development, because of the gentrification, sort of the neighborhood dynamics were being interrupted. So some of those pillars of the neighborhood, some of the OGs, as they call them, or Big Mama. Some of them were being going to other neighborhoods and other communities. And so when they were sort of keeping the community together, and they were sort of the gatekeeper of like what was good for the community, what wasn't good for the community, we found that violence was starting to increase because those buffers were no longer there. So we had to think about, how do we reintroduce buffers into those communities? And through the healing circles, some of those buffers, some of those mentors, some of those community leaders rose out of that work. So again, I just elevate healing circles and restorative justice as practices that we found to be credibly incredibly useful in the work that we're doing in reducing violence in all forms, including sexual violence. So again, I just convey to you all, if you haven't used this approach, I'm happy to talk to you more about how we instituted it. And it took some time. Early on, there were not very many people were showing up to the healing circles. It had to be word of mouth, and we had to have the folks in the community sort of bringing in other folks to attend. I'll say, when I try to recruit people, it was not happening, but there were others who were more in touch with community, and they were trusted sources, so they were able to bring them to the healing circles. And now that this program is over, I'm happy to report that they're still doing them monthly. And they're becoming more and more inclusive, where they're talking about a host of issues related to identity and violence. So again, I just offer that up as a great resource. In closing, I just wanted to lift up that in order to do this work, we also have to ensure that within our own organizations, we are operating in an equitable manner, and we're ensuring that we are really building equity principles and practices in our own work. And a tool that we often use with some of the folks that I provide TA to is Awake to Woke to Work, building a race equity culture. And again, there's a focus on racial equity, but I think this can be brought in to focus on other aspects of equity as well. So when we think about Awake, you're focused on people and building a workforce and boards comprised of individuals from different race backgrounds. And the primary goal is representation and diversity. So that's when you're Awake. Then you elevate to Woke. This is focused on culture and on creating an environment where everyone is comfortable sharing their experiences, and everyone is equipped to talk about race and equity and inequities. And the primary goal is inclusion. And then we get to the work where we start to operationalize it, right? It's focused on systems to improve race equity, or equity again broadly. And the primary goal is the integration of an equity or racial equity lens into all aspects of the organization. So with that, we have a question for you.
Yes. Okay. So I'm going to launch this poll, and then Mighty, maybe if you don't mind going back to the previous slide, so
Sure.
folks can see
where they are.
Yeah. All right. So I just launched the poll. So if you're not seeing it, try clicking on the tab at the bottom. And there's 4 options: awake, woke, work, or not on the spectrum. Really just looking at where your organization is on the spectrum of building a race equity culture.
Awake, okay.
Yeah, and if you can't access the poll, go ahead and put it in the chat. That is fabulous.
Yeah. The other one I should add, in jest, but in all seriousness, that there's some organizations that are still asleep. Hopefully, none on this call, but there's still some work to be done to even get folks to awake. So, it looks like the majority of folks are around the awake piece, which is a great start, and hopefully, you all can use this tool to move the organization forward.
Mm. Okay, I'll share the results. I did also put a link in the chat where you can, I think you have to maybe enter your email address, and then you can download the Awake to Woke to Work
Yes.
information. Yeah. All
Yeah.
right, I will share
Yeah.
those.
Thanks, Ashley.
Great.
And yeah, and what I would like to offer to folks too is that some of the tactics that are not sort of in the toolkit, happy to share with you all some of the work that we've done with organizations as we've done assessments. Sort of, we look at a racial or equity assessment of an organization, because we find it to be disingenuous if you are saying your organization is doing health equity work, but you're not taking time to do some internal introspection to ensure that those same principles that we're promoting, you are operationalizing within your own organization. So it's with some, that there's some nuance there. So happy to help you all work through that. And my email is included on the slide. So feel free to reach out to me if that support is needed. Yeah, I would a hierarchy in some instances. I would say you do want to be able to move depending on the work that you're doing, right? And what's the mission, the vision of your organization. A lot of this comes from not a lot of it, but I would say we really stepped into this work after this big call for sort of like diversity, equity, and inclusion, and folks were posting all of these showcasing these ways that they are supportive of an inclusive work environment using a health equity frames or a health equity frame or DEI framing. But we found that a lot of that was I won't say a lot of it. In some instances, it was performative. And again, my glass half full perspective, I want to think that it was well intended, but the intention is not enough. If you are really going to step into the space, you got to really fully do the work and operationalize it. And so helping you all get from the awake to the woke and operationalizing it. Here's another tool that I find to be helpful. It's an equity, diversity, and inclusion self-assessment tool. Now, keep in mind, it's intended for small nonprofits, but a lot of what's included in the guide, I think, is applicable for all the organizations. And what it really does, it presents an opportunity for you to sort of like scale back and do a deep introspection and a dive on your organization to really see how inclusive are you? What are you doing for equity? What are you doing for, so it's like, it's intended for you to be inclusive. So again, happy to work with you all and talk about how we've used that work, how we've used this in our work. And I'll stop there for any questions that folks may have. I was trying to, it's not letting me advance, but just so you have my email in the event. Oh,
Let me see if I can get. So yes, the resources, all of the resources that were discussed in the presentation are on that resource sheet. There's been a few shared in the chat that I'll probably add. And so when I send a follow-up, maybe just check for the newest version. Maybe let me try to get your email up on the screen. Sure. And yeah, thank you so much for all of this information, Mighty. I feel like there's a lot here. We said this is like building a foundation, and I feel like it really is, but we could dig into like every piece of your presentation and do an entire webinar series on those. So yeah, I'm gonna put can I put your email in the chat? Is that okay? Because I'm not able to do that either.
Sure.
Okay, I'll put that there for you all. So yeah, we have some time left for any questions that might have come up. And there's also one more resource that I just want to show you. So APHA has a range of resources related to racism and anti-racism work. So I'll put that link. No. And the link should stay the same. So you should be good to just refresh on that. And I'll get to that this afternoon. But yeah, any questions coming up for you all? We have some time. Mighty, I just really want to thank you for sharing about some of the work that you all are actually doing around health equity and violence prevention, because I do think that those examples are so important. It's one thing to be able to talk about it and explain it, and it's another to see it actually in practice and in action. So thank you so much.
Sure, absolutely.
And I'm seeing, yeah, do you see there? So there's a question coming in from Laura, asking if you would talk a little bit more about the equity barrier, myth of zero sum, especially how it masks the cost of inequity and cost of violence in particular.
Yeah, for sure. I think because when at least my interpretation of it and how I've applied it to violence prevention is that it's this idea, so it's the myth of zero sum, but it's also the concept I learned in urban studies, sort of NIMBY, right? Not in my backyard. So it's almost as if that's a them problem and not a my problem. And it allows us to negate the fact of the historical injustices that create environments where violence is more likely to occur. And then it just so happens that they tend to be in communities of color. So then it aligns with this idea that there's a proclivity for people of color to be more violent, right? And they don't want better for themselves. And so it's this idea that it almost is a way to justify these racist ideologies around violence and violence prevention, particularly when you think about violence, homicide, for example, being a leading cause of young Black men. And I found that folks have used this as a way to explain why they're sort of hands-free of it, or why they're not doing anything to address it, because it's taking away from people who really want to do better, right? As opposed to recognizing that this environment is creating this from happening. And if we're using an equitable lens, we will say, hey, these communities don't have green spaces. These communities don't have trees. These communities have schools that are overcrowded. There was sometimes when I give this talk, I use a clip from, I think it was called Shell Shock and it was about the violence in New Orleans. And the kids talked about how it's easier for them to get their hands on a gun than it was a book. So whose issue is that, right? That's our collective issue to address, recognizing that kids are telling us in their community it's easier for them to acquire an illegally obtained firearm than it is for a book, because the resources in their school are lacking. So again, when you do the zero sum, it allows us to shift and not pay attention to the critical needs of our communities. I don't know if that answered your question, but clearly you could tell that I'm this is an issue of mine, so I won't get on my soapbox, but I could talk about that for a long time, about how resources are not distributed fairly. Thanks you, Laura.
So I did, please, if there's more questions, keep them coming. And I just saw one pop up from Katie. But we did, want to just also kind of hear from you all about maybe an action step that you can take to incorporate a health equity approach, a health equity lens into your prevention work. So be interested to hear from you all on that. And then let's see. So Katie's asking if there's any helpful visuals or exercises that explore the intersections of public health, racism, and relational violence. And then lots of kudos for you, Mighty. But I have that question too. Have you seen anything like that? I feel like that's something that we've actually been talking about with some of our national partners. And so I don't know if there's a need there that it needs to be created, or if you know of anything.
Yeah, not the visuals that I think about. Again, I turn to her because I think she's one of the leading researchers in the work. But Kamari Jones has some graphics that she's used for You all may be familiar with the gardener's tale. And she uses that, and there's a graphic that's associated with that to show how there's a preferential treatment. I think of red flowers over pink flowers, and it's an allegory just to show how racism operates within society, both through commission and omission, right? So yes, if you email me, I can send you a copy of that paper that has that in there. She also has some other graphical depictions of how racism operates using allegories. And I believe that they're publicly available. So if you send me an email, I can send that as well. And I can say here, we haven't approached her yet, but there's some work at APHA that we're hoping to do in partnership with Dr. Jones in taking some of that, like the 7 pillars, and making a graphic depiction of them. So it's something that folks can readily use in their presentation. So that way we're really saturating the space of public health with thinking about those pillars or those barriers to health equity. And then on the counter, how do we retrofit our programs, policies, and practices to address them so that way we overcome them.
Mm-hmm. That there were a couple of questions about graphics related to those pillars as well, Mighty. So it's great to hear that might be something coming, and I'll be sure to follow up with you on that because it sounds like it would be very useful to participants here today.
Yes, I feel more. Yeah, I would suggest also the graphics that I use. I think you posted the source in the chat, Ashley. I think those are a great way to get folks to think about equity and equality and social justice. And I think the graphics to depict racism can be a riff off of some of those for sure.
Absolutely. Let's see, there's a couple more comments. I'll just answer real quick. Vanessa, yes, you'll receive a email when the recording's available, so you know that it's up and you can access that.
Yeah, and I see Elizabeth put something in here too. It's sort of like early on in public health where we talked about race as a risk factor, right? And we had to reframe how we talked about race as a risk factor because again, it's putting the onus and the responsibility on the person and saying that because you're Black, you're more likely to this, but we know it's not about my phenotype, right? Or my biology, it's about the circumstance and the environment. So we had to shift how we talked about that as well, and identity in general.
Mm-hmm. Yeah, being able to really kind of drill down on it's not the risk is not connected to identity, it's connected to the environment and the conditions that exist in the environment. And that can be, I feel like there's so many uses for graphics in some of these questions because it can be hard for people to kind of grasp, but I feel like once they're able to connect those dots, it kind of opens up like, oh, okay, this all makes sense now.
Mm-hmm. Yeah, for sure. Yeah, even around the what's the graphic we use in public health all the time? The river analogy, the upstream, Yes, absolutely. Tamara, I'm not sure if I'm pronouncing your name correctly. Race is not real. It's a made up construct for sure. And I think there's a lot of history around that, and we recognize how it plays out in today. Again, with intentions behind the fostering competition as opposed to cooperation. So it's something that I think we're constantly working to elevate, but also change. And I do recognize there are lots of you on the call. And again, I feel like I was a lot of sort of snippets of information. Just wanted to make sure you all had a taste of what we're doing at APHA, so we didn't go into much depth about any one piece of that. But again, I don't say this just because I'm here, but I'm really available to talk through some of this with you all because I'm very both personally and professionally invested in this work. And I think it's going to take a collective of all of us and all of our identities if we really want to advance health equity in an intentional and meaningful manner. So if there's a way that I can support your work from any of the things that we've done, or it'd be great to learn from the work that you all are doing. Again, so we're bolstering our capacity to address this issue with some conviction and intention.
Thank you, Mighty. There's so much happening still in the chat. I'm trying to keep in tabs on it. I think that so a potential follow-up or series planned. There is some follow-up that will be happening, and so the best way, hopefully, y'all are on the mailing list. That's typically how we communicate things out. We don't send too many emails, but yeah, this is, a huge. There's so much that we could take
Sure.
To continue this, right? There's like so many avenues that fall into this discussion, and so it's great to see so much great feedback and ideas and work that's being done, so we can kind of gauge where we go next with this.
Sure.
So all of your input is super, super helpful. And what was the other thing I was going to say?
I will just,
know.
I would just add to that, Ashley, too happy to come back later on as things are sort of morphing along to talk specifically about some of the work that we did with the community here in DC to get to where we were able to implement the healing circles, do some of the restorative justice, doing some of the other protective things that we know are effective in preventing violence. But again, thinking about it from a systems level and not just focusing on the individual, and talking about some of the challenges that we face as well, if there's an opportunity for folks to learn from that too. Happy to come back at some point in the future to chat about that.
Thank you so much, Mighty. And I will just encourage you all, our last podcast that we put out on Prevent Connect was looking at critical race theory and anti-oppression and violence prevention, and featured some work from some other state coalitions. And they have kind of a roadmap to that. And so that's also a nice visual. So check that out. But yes, I just want to, it felt like we had so much time and now we're right up at the end. So I just want to really thank you all so much for such an active web conference. I know that, we really rely on you accessing the chat, and that is not always the optimal way for people to communicate, but it did feel like there was lots of engagement and we were able to hear from so many of you. So thank you for that. I want to thank our captioners. Mighty, thank you. I mean, the amount of information that you brought to us today is just incredible. There's so many resources to dig into and kind of new frameworks and approaches to think about as we look at how our work advances health equity. So thank you for that. We will be sending out, as I said, a follow-up email. It'll have a link to a brief evaluation survey. At the end of that, there's a link to a certificate of attendance. So we really appreciate your feedback and want to get you that certificate. If that's something that you are interested in, send the link out when the recording's available, and I'll update the resource document. And then we will figure out where we go next with this conversation, because it's clear that this is something that is really resonating with you all. So, and we do not, I'm sorry, we do not offer CEUs. I can offer a certificate of attendance. Oh my gosh. Okay. Thank you all so much, Mighty. I'm going to just turn it back to you for a minute to say goodbye.
Sure. Thanks again, Ashley, for creating the space for us to have this dialogue and this engagement. Appreciate you all for being attentive and actively participating And hopefully what I shared is useful in some manner. And again, happy to connect offline as you all see fit.